Most patients are put through a multidisciplinary team.
Even two patients of similar cancer are treated in a different way. We go up to the DNA level of the individual tumor.
So there is a concept called organ preservation, in which the surgery to that organ would be highly debilitating to that patient. The commonest example is the voice box. Earlier, the surgery for the voice box was the only option.
You're treating a tumor, you need to make sure the other surrounding structures do not get the dose. So there are guidelines given that your brainstem gets such a dose, your spinal cord gets some dose.
For example, in breast and ovarian cancer, unfortunately in our country, we're not seeing very early disease.
The patient undergoes a significantly less complicated surgery or a complex surgery. You can reduce the surgical side effects. You can give a better cosmetic appearance to the patient, suppose in case of breast cancer.
People bear fear with what they haven't seen, what they have heard.
Partially, half information.
Correct. More time you spend with the patients addressing their queries and questions before the start of the treatment, more effective your treatment will be and more cooperation you will get from the patient.
Because the patient is
Absolutely.
well aware about the entire
Absolutely.
thing. Today's episode is one that goes beyond science. It's about courage, it's about hope, and it's about fight. The fight which we all recognize as fight against cancer. Cancer is just not a diagnosis, it's a storm. It's a storm that tests every part of a person, be it mind, their body, or their willpower. But in this storm lies beacons of hopes, brilliant minds who have dedicated their entire life in turning this fear into survival and despair into determination. Today, I have the privilege of speaking with some of the finest minds in oncology, each a leader on their own right. At the helm is a remarkable force in cancer care, Dr. Shona Nag, Director of Oncology, Sayadri Hospital, whose vision and collaborative spirit have shaped not just protocols but people. The team around her, experts in medical, surgical, and radiation oncology, reflect the strength of that leadership and the shared commitment to delivering exceptional patient centric care. Together, we will unpack where we stand in this war against cancer with compassion, precision, and unwavering commitment to all lives which is touched by this disease. Hello and welcome to Sayadri Health Talks, a very special edition. Why special? Because I have the entire team of oncology from Sayadri Hospital, Harap sir. Without further ado, let me introduce you to the panel. So we have with us Dr. Shona Nag ma'am, Director of Oncology, Sayadri Hospital, Dr. Srinivas sir from the Department of Medical Oncology, Dr. Sanjay sir from the Department of Radiation Oncology, and last but not the least, Dr. Jay Ghosh sir from the Department of Surgical Oncology. Welcome on today's podcast, sir. And ma'am, how are you feeling? How all of you are?
Doing very good, thank you.
So I'm very excited and, to be honest, a little nervous to have this entire panel. So we will talk about oncology and something very basics about oncology. So I would want to start with our very own Shona Nag ma'am. So ma'am, as a director of oncology, you have always spoken about the role of multidisciplinary team approach. So why is it so, and why is this multidisciplinary team approach so important in cancer?
So I think that's an excellent question. And just to give you a background, 100 years ago when we started treating cancer, it was what we called a linear approach. So it was the surgeon first who tried to remove as much of the tumor he or she could. Thereafter, the tumor used to inevitably come back. It went for radiation. And the last port of call was the medical oncologist, where some sort of medications, chemicals, very, very basic chemo was given. Then they realized that it was not the linear approach, but 3 or more treatments of cancer to be done together with the inputs of the pathologist, with the importance of imaging to diagnose and pick up cancer early to find out where all it has spread. And that gave the highest success rates. So today, Most patients are put through a multidisciplinary team, and having regular tumor boards, which are attended not only by the surgeon, medical onc, radiation onc, pathologist, the junior students, the radiologist, the PET scans, nuclear medicine specialist. What it does is it gives you an entire framework, especially in difficult cases, on how to proceed further. It also gives you different points of view which can be integrated to form a good consensus for that particular patient. And today it's well documented that patients who are treated in a multidisciplinary fashion with the inputs of all the experts combined do much better than when they are treated by a single person. I don't know if my colleagues want to add anything.
No, I think it makes sense because it basically means looking at the disease and the patient from a one-dimensional view versus taking multiple viewpoints and combining them together to give the best output to the patient.
Absolutely.
So, ma'am, as as a multidisciplinary team approach and as a director of oncology, I'm pretty sure there are some challenges and benefits. So, we have already spoken about the benefits here, that how it benefits the patient. So, if I have to ask you that, do you face some challenges also in this approach to manage a team which is such a huge team panel?
Managing people is not easy, and you know that, and everybody comes with a different perspective. But as long as you pick people who are kind of devoted or sincere in their approach, who have a good level of competence, and whose main kind of ethos is to work for the interest of the patient, I think you're okay. It's not been challenging because all of us so far are very patient centric, and we also try to keep up to date with what is happening latest, so we can kind of offer more beyond just the standard of care. We do think of different approaches, and we kind of keep brushing up our knowledge. So I don't think it's been a real challenge. There are the little problems that come day to day. Some people do leave, some new people join. So attrition is always an issue. It is more the junior lot. Then always keeping up with technology and keeping your teammates satisfied sometimes is a problem. But over and above, it's not been.
It's more beneficial.
Yeah,
the benefits are more than
there
the
are much more positives than
positives
negatives.
than
Yeah,
negatives.
yeah.
So, wanted to ask about this precision oncology. There is a lot of talks happening on precision oncology. What are your thoughts on those?
So I will defer to Dr. Srinivas because he's a new age oncologist and he has a lot of information on this.
Right. So, as rightly pointed out by ma'am, maybe couple of decades ago, we used to treat the cancer patients with the blanket treatment. Whatever may be the cancer, some common chemotherapies were used to be given to start with.
Carpet bombing, commonly known as.
Yes. So nowadays, what is happening? We are actually moving from generalized term to more individualized treatments, and we are treating each and every individual in a different way. Means even two patients of similar cancer are treated in a different way, and there comes basically a concept of precision oncology. It simply means that we go up to the DNA level of the individual tumor. We find out what are the mutations that are being seen in a particular tumor, and we specifically target them with the help of either targeted therapies or some form of tablets or immunotherapies. And why it is important, nowadays the precision oncology is coming up in a big way, is that along with treating the cancer, we are able to maintain the quality of life of the patients when we are using a word precision oncology with the help of finding out each and every individual mutation. So we are treating every cancer differently based on their nature. Whatever mutations are there in the DNA, they are treated accordingly, so that we can getting rid of chemotherapy related side effects, improving quality of life and managing cancer patients in a better way.
Okay. So, sir, my next question is to you. So, when you have to decide a call, when you have to take a call for surgery, how do you decide like which cancer patient requires a surgery and what could be the type of surgery?
Yeah, so if you look at the types of cancers, broadly they're divided into something called solid tumors, in which there is a tumor growing in the body, and there is another group of cancers which are related to blood, lymphatics. So that's a different complete subgroup of cancers. When you come to the solid tumors, practically 90% of these patients do require surgery for a cure. And if and when they are evaluated and found to be operable, you are going to offer surgery at some point in time in their treatment to 90% of these patients. So the saying still goes what it used to be 30 years back, that without surgery a cure is unlikely in majority of these patients. So most of the patients do require surgery.
So, how does radiation therapy change between the late and the early stages of a cancer, sir?
See, again, early stages are those which are like stage 1, probably stage 1, stage 2. And if you talk of late stages, it is locally advanced, where you treat. Now, to tell you how precisely, I can tell you an example of breast cancer. The most common cancers in India, again, breast cancer, where you see late stages, probably with a node positive, who has been operated, who's been given chemo. The traditional way of treating is almost 15 days. That's a way of treating 15 days of treatment. But there are a few early breast cancers we get, who was just operated, elderly, who don't require chemo, very good prognosis, stage 1, probably will cut down from 15 days to 5 days. So basic difference is the overall dose remains the same, but number of days they're getting treated, the number of fractions are reduced. So that gives an additional advantage. That's what picking up early cancers, treating early cancers, exposing them to lesser radiation as much as possible.
So, are there any, typical cancers which, have better results with radiation therapy only?
See, it's historically known lymphomas do very well. Lymphomas respond to chemo also very well and radiation also. And traditionally we see squamous cell carcinomas. Any squamous head and neck cancers are again squamous cells, esophageal, GI tumors and all squamous cells, they respond very well. So sometimes you avoid surgery in cases where they're not operated and you give radiation and chemo, you get almost comparable results to surgery.
So to give you an example of what he's talking about, and you asked the question of when surgery is required, so there is a concept called organ preservation, in which that the surgery to that organ would be highly debilitating to that patient. The commonest example is the voice box. Earlier, the surgery for the voice box was the only option, removal of the larynx. And that would lead to a loss of voice in that patient. Today, 90% of these patients don't require that because of radiation. And radiation can completely cure the cancer in the voice box today. So all of those patients are treated with radiation. Only the ones who are unable to be treated or fail, then surgery is the last option. But now that shift has happened, in which radiation is the primary treatment and surgery is the secondary treatment.
So similarly, sir, what are the cancers which where you recommend, chemotherapy or radiation before surgery? Apart from
So
this,
as cancer care has moved on, earlier it used to be that practically everybody would undergo the surgery first, and then as madam said, that radiation and chemotherapy would be added on. Today, if you see, practically in all cancers of the body, whether it is stomach cancer, whether it is lung cancer, it could be cancer of the ovary, all of these cancers require some treatment before to reduce the size, downstage the tumor. So chemotherapy, radiation is used in a lot of, so maybe 60-70% of the patients require some treatment and then go for surgery in the later stage.
For example, in breast and ovarian cancer, unfortunately in our country, we're not seeing very early disease. Ovarian, as it is mainly diagnosed 75-80% in a stage 3.
okay.
And if you look at breast in India, not even half the patients come to you in an early stage. Most of them come in a late stage 2 or early stage 3. And there we prefer to shrink the tumor with upfront chemotherapy, targeted therapy, and then operate the patient, and then possibly radiate the patient.
And the biggest advantage of doing that is the patient undergoes a significantly less complicated surgery or a complex surgery. You can reduce the surgical side effects. You can give a better cosmetic appearance to the patient, suppose in case of breast cancer. You can give a better outcome in terms of reducing the chance of recurrence in the future. So these advantages are always going to be there when you use some treatment to downstage the cancer before operating.
And like he mentioned, organ preservation, so you save the breast.
Correct.
Even if you couldn't save it initially and the tumor was too big, today with our treatments we shrink it. And for a woman, having a retained and perfect body image is so important for her confidence. So it makes a big difference to the psyche, the acceptance and the quality of life of the woman.
Okay. So how do you deal with the patients have fear about chemotherapy, right? And as a layman, the most first and the deadliest side effect which comes to mind is hair loss in chemotherapy. So I'm very sure patient keeps asking you day in day out such questions. So how do you deal with such side effects of chemotherapy, and how do you counsel them?
So the only solution to such kind of fear in the minds of the patients is actually an effective communication.
Acha.
People bear fear with what they haven't seen, what they have heard,
Partially half
correct,
informations.
what they have experienced with others, not with their own experience.
body,
Probably
yes.
too much of Google. They Google. Someone comes to me, they always come with complications of chemotherapy, complications of so and so. So it's very difficult at that point of time.
So, when a patient is diagnosed with a cancer and we are planning for chemotherapy, it is very important to spend some time with the patients and ask them ki what fear they have in their mind, so that we can specifically address those issues. And I'm sure, and I have experienced this in my clinical practice, more time you spend with the patients addressing their queries and questions before the start of the treatment, more effective your treatment will be and more cooperation you will get from the patient.
Because the patient is well aware about the entire thing.
Knowledge is power today.
Correct.
And the unknown is very frightening.
Frightening.
What
And I
about
think-
our hair loss?
Yes,
She
exactly.
was-
About hair loss, I think we have the
Right.
ability to
So,
reduce.
so it can be tackled by two ways. We often explain the patients that you might land up in some form of degree of hair loss over a period of time during this treatment. So there are certain subset of patients who accept the facts in a healthy way. That there are certain subset of patients actually who they want their hair to be preserved. So in nowadays in our clinics or in our practice, we do use something called as advanced techniques.
Okay.
And we do use something called as scalp cooling techniques, and
Acha.
we start the patient on ice helmets. These are
Okay.
called as scalp cooling machine.
Okay.
They have been connected just before the start of the therapy, and they remain connected half an hour or 1 hour after the chemotherapy is over. So
Acha.
what does it does actually is that it reduces the extent or the proportion of chemotherapy reaching the scalp, which
Acha.
usually results into hair fall. And
Acha.
it reduces the extent of hair fall, rate of hair fall. And one of the better advantage of scalp cooling caps in long term future, those patients who use it during the treatment, they have their hair growth in a rapid way. The rate of regrowth of hair is actually better in patients who haven't used it. So there are multiple advantages of using such kind of scalp cooling
coolers.
caps.
And there are some types of chemotherapy, for example, docetaxel, paclitaxel, where this machine works better.
Acha.
And there are some where it doesn't work as well. So you've got to tell the patient that. And like Dr. Srinivas said, the regrowth is better, the quality of hair is better. And one side effect people don't talk about with hair loss is delayed alopecia. That is, after 6 months, they can also start losing their hair. So this is where the scalp cooling machine comes in. It prevents delayed alopecia and improves the quality of hair growth.
So when it comes to the radiation part of oncology, right? So are there any parameters, or how do you decide the dosage and the treatment plan when it comes to radiation oncology?
See, there are set of guidelines given. I mean, we have an Indian guidelines, we follow European guidelines, Astro guidelines. There years of trials done. They come to particular dose. It's like how it is developed from phase 1, phase 2 and phase 3, and they're all decided based on your organs. The radiation is all about precision and accuracy. You're treating a tumor, you need to make sure the other surrounding structures do not get the dose. So there are guidelines given. Your brainstem gets such a dose, your spinal cord gets some dose, your parotids when you're treating head and neck gets some dose. So we make sure we target the tumor with the guidelines and make sure we keep the normal tissue under constraints and keep the dose weak. Suppose you're treating head and neck cancer, I'll tell you an example. We go up to 60, 66 gray. We cannot shoot beyond that. Now why we cannot shoot beyond that? Because that's a guideline given. Even if you try to shoot, you'll be damaging the other important organs. So you need to make sure how to understand. Basically in radiation there's a little bit technical. Normal tissue NTCP and TCP ratio, normal tumor control probability and the tolerance level, and also look at the toxicity level. So you make sure that is always met and decide the dose what you want to give.
So sir, how do you choose over when it comes between chemotherapy and targeted therapy?
Right.
No, I think that's an excellent question. Yes.
So, it has various aspects, ma'am. First of all, it depends on the type of cancer that you are dealing with.
Acha.
Second thing, there are certain parameters that we check whether this patient is eligible for targeted therapy or immunotherapy or no. And third, most important thing is basically the symptomatology of the patient.
Acha.
Sometimes, we have to incorporate chemotherapy along with targeted therapy if the patients are quite symptomatic, to get the rapid relief. But sometimes when we are actually giving immunotherapies, we have to invariably combine them with the help of, chemotherapy, so that immunotherapy might take some time for its action. So eventually, in clinics, it depends on the type of cancer, the nature of the tumor that you are dealing with, and how symptomatic the patient is. So these factors actually decide whether to start with chemotherapy or targeted therapy, or combination of chemotherapy plus targeted therapy, or chemotherapy plus immunotherapy.
One thing, before thinking about targeted therapy versus chemotherapy, you have to identify a target.
Okay.
Right.
Targeted therapy means that there is something in the tumor in the patient's body that you can target with a specific medicine. As you mentioned, precision medicine. So there is a medicine which will only go and target that particular cell, and it will kill that cell. So unless that target is there, they cannot be offered targeted therapy. So initial evaluation is that whether the target exists in that patient, and then the choice can be made. If a target doesn't exist, it's going to be probably only chemotherapy.
So one of the success stories for targeted therapy is lung cancer. And it's been quite amazing what has happened in the last 20 years. Normally patients with lung cancer are always diagnosed in stage 3 and 4 and more stage 4. And at one time, I remember when I started practice, the survival was 6 to 8 months. Then with one chemo platinum, it came up to 10 to 12 months. That added literally 2 months to the survival. Then we started using a combination chemo. So it became 15, 16 months max was the survival. Today, because of targeted therapy, we are able to find mutations in more than 50% of lung cancers. These are certain changes in the DNA we see in the tumor, and we are able to target them with oral targeted therapies.
So that precise.
And the average survival of a stage 4 patient can be 4 and 5 years.
Acha.
And with immunotherapy, which is also another success story, the Nobel Prize for Medicine was given a few years ago to Allison and Honjo, 2 people who discovered immuno for lung cancer. And there also the survival has been in many years in a stage 4 patient. And we all have such patients who are doing so well.
Right from a survival span of 4 to 5 months.
Yeah, 6 months.
We have gone to
now we've gone to 5,
5+ years.
sometimes 8, and it's just so
And it is
rewarding.
getting better. It's getting better.
Yesterday, to just add to that, yesterday I was in a lung cancer conference.
Acha.
Now, as a radiation oncologist, it was really fascinating. As madam said, we start with, before operating, we do some chemotherapy, we downsize and operate. Now, it's all more into molecules. You give targeted agents with chemo, downsize. Sometimes it is so well, sometimes we even don't operate. So it is that which patient is put on maintenance of targeted therapy. Even metastatic diseases like stage 4, mets in the brain, mets in the here and there in the bone, they're also on maintenance and they're doing fantastically well.
And it not only prolongs the survival, it maintains the quality of life.
Brilliant.
The quality
You
of
can't
life.
tell it's
Yes,
a patient.
Yes.
So I have women and men going to offices, leading their normal lives, driving their cars, going on holidays, and it's absolutely fabulous.
So, ma'am, as Sanjay sir just spoke about metastatic cancers. So, metastatic cancers, so basically metastasis. These cancers typically require all the 3 specialities. I mean, in general, at some
usually
point.
radiation and chemo more than surgery.
Okay.
Yeah.
So, in such cases of patients, what are the challenges which you commonly face, or how do you handle those?
So stage 4 patients are always difficult in the sense you can't cure them. You have to be very clear of that. Though you can give them many, many years of survival, at some point the cancer gets resistant and starts to grow. When you see a person with a stage 4 disease, you've already in your head planned out treatment 1, treatment 2, treatment 3. You can't just go by treatment 1. You've got to have the backups ready. You've got to use your drugs very carefully. At the same time, You've got to get rid of those symptoms that they're suffering from and maintain the quality of life. So the focus is more on symptoms, quality of life, and then prolonging the survival. It is challenging because as you can't cure the patient, there is a definitive lifespan. And it's very difficult for the family, and especially the younger patients we see today. I mean, it's okay if I tell a 75-year-old, not too much time left, it's a couple of years or whatever. But if I'm telling a 45-year-old that,
Very difficult.
it's very difficult.
But we have something like, suppose, oligometastatic. Now the trend is so much, lot of trials.
So explain
oligometastatic.
oligometastatic.
Oligometastatic is basically against a stage 4 disease, but limited meds, probably 1 to 5. You don't have more than 5. That's a definition, by definition, oligometastatic. And then you can think of cure, but not in all cases. It depends on multiple factors like patient general condition, how fit is he, what options you have of immuno or chemo, as he said, whether you can target, if no surgery, with a high dose radiation to that area. Basically, you are again giving a better quality of life but not compromising this cure.
So that makes up a small part of metastatic disease.
Acha.
You want to add something for
Yeah, so
metastatic?
in metastatic setting, when we are talking about challenges, these are actually real scenarios where the precision oncology comes. As madam has rightly pointed out, we have to think of sequence of treatment options that you have in the first place itself. So we keep on ending invariably. For all metastatic patients, madam will also agree that we are doing, there is something called as next generation sequencing technology. It means gene mapping of the tumor. So if you have used 2 or 3 lines of chemotherapies, then there is always a question that what next? If you have an answer to this question, that if you have done a gene mapping of a particular tumor and if you have some particular gene abnormality and you can target it with the help of tablet or targeted therapy, your next option also comes into the picture with a more effective way.
So this is what Dr. Joy was talking about when he said that to be able to use targeted therapy, you need a target.
Target first.
And we do spend a lot of time and resource, especially in metastatic disease, looking for these targets.
And one thing I would add is that thankfully, and as time passes, it will get better. The cost of these investigations, which is sequencing the genome, finding out the DNA, finding mutations, earlier used to be exorbitant and not affordable by the common person. But because of a lot of research, a lot of labs coming up in India, a lot of genetic information databases being created, I think the cost has been brought down very significantly, and it allows us to use these targeted therapies because now you can use the test for those many patients. And if that wasn't there, then there was no question of giving the treatment.
So the technology has come to India in a big way, and what used to cost lakhs of rupees, today we can do a good comprehensive gene sequencing in 40 and 50,000, which is still expensive but still more affordable.
It's slowly coming
Correct.
down.
Correct.
So coming to the radiation therapy again. So what is the difference between the stereotactic radiation and the traditional radiation therapy?
So traditional radiation is like, it's all depends on number of fractions, number of days you're treating and the dose. It's all you're playing around with the dose and the fractions.
Correct.
So traditionally what we treat almost 3 to 4 weeks, 4 to 5 weeks. That's a traditional way of treating any tumors. Now SBRT has come up in again oligometastatic we discussed. If it is a small disease somewhere in the brain, in the bone, you target, you give a very high dose. So SBRT is one of the techniques of radiation. Traditional radiations are like, different techniques like IMRT, intensity modulated radiotherapy, IJRT, rapid arc. These are the traditional way of treating for a longer course, maybe 4 to 5 weeks. When it comes to SBRT, it's a very fine, it's like ablative dose. It's equivalent to surgery. Sometimes when a surgeon can't go and operate, you don't get a metastatic, you give a very high dose. Suppose I'll tell you there's a small tumor in the brain, maybe 2 centimeters or 3 centimeters. You give a very high dose only to that small part. It's very focused radiation, giving a very high dose, but at the same time, meeting your criteria for saving the normal tissues by not damaging them.
So that is like stereotactic radiosurgery.
Acha.
SRS.
It comes into play. So many a times, you want to operate the patient, but due to the patient's other illnesses, maybe long-standing diabetes, heart disease, somebody
blood thinners
yes.
or
So
something like
maybe the patient is not not fit to undergo that surgery. What is the option then? That you have a tumor, it's curable, it's small in size. What do you do? So in that aspect, stereotactic radiation has come in a big way because it allows you to give such a high dose of radiation to such a small area that it acts like as if you operated that area and you removed an entire tumor and it's completely gone now. So it's a replacement for surgery when you can't perform the surgery in that patient. So you can think of it in that way.
I'll tell you an example, like suppose I'll tell you lung cancers. Definitely the guidelines, stage 1 lung cancer, it is always surgery. But there are medical comorbid condition, patient elderly, not fit for surgery, has COPD, smokers who cannot tolerate the anesthesia. Then there's an alternative for surgery, that is don't give chemo, don't give immuno, just target with a high dose of radiation. No doubt results are not, surgery is anyway superior, but this is one of the options because you are not operating, you are not doing anything but you are radiating them, give him that control possible which is equal to surgery to some extent.
So we have spoken about SBRT. So SBRT and proton therapy, are these two same? What is it about this?
No, they are not same, totally different. See,
Acha.
SBRT is how given by Linux. So basically radiation therapy is by particles. It's a
Okay.
particle therapy. So photons are chargeless particles. All linear accelerators in India, any kind of machine which radiates, all have photons. Now from last 10 years or probably in the Southeast Asia, we started with the heavy ion particles like protons, carbon ions. They are literally heavier than the photons which are there. They are charged particles, positively charged. So the way they penetrate the body, the way they exit, their physics characteristics are totally different. So proton is one such heavy ion particles where it is used to treat patients. If you want a real simple answer between SBRT with photons and protons, when you radiate a lung tissue or a breast tissue, there's always an entry dose. Radiation is nothing but an X-ray, very simple. It enters and it exits. So the exit point in photons is always from other part of the body, but
Acha.
protons always stops midway. It doesn't exit. So when there's no exit, it saves most of your structures which are coming in between. Like you go through breast, you go through lungs, you go through esophagus and spine and all beyond. But protons has a Bragg peak where it stops much before the exit doses. So that's why the complication rates now has reduced. But in India again, the cost being an issue because Chennai Apollo has only one and now TMH has also come with that. But again, the resources, the logistics, cost is almost, if I tell you, some 5 to 6 times more than what we do traditionally with our treatment here. So there we are lacking basically.
And it's not meant for every tumor. I mean, I think 90-95% of tumors you can get away with good planning, whatever he mentioned, a good linear accelerator with all the software attached to it. Proton comes in that 5% or 7% of patients where you have very deep-seated tumors and you want the maximum dose without the exit dose causing all the side effects.
If you ask me where you use, I would suggest definitely if a case comes, I would refer to protons or pediatric tumors.
Okay.
See, where really matters the most. Your lifespan is you are going to live long, you're going to live without toxicity if you're treating with protons. Somewhere where it is brainstem tumors, gliomas, brainstem gliomas, where tumor is sitting inside the brainstem. You can't do anything but to give some proton, try to spare the normal structures. Chordomas, basically all this base of skull tumors where it is not possible to operate, and treating with a photons or SBRT or linear accelerator is going to give you more complications than curing the patient. So such patients we need to select. There are very handful of them right now.
So, sir, when it comes to organ removal, right, during a procedure or a part of treatment, how do you talk to these patients and how do you deal with such patients? Because organ removal is something which is very sensitive,
Absolutely.
So, how do you deal with this?
So yeah, it does become difficult sometimes because especially when the organ being removed is going to change the person's life in a big way. For example, if you take rectal cancer, that is the end of the intestine. If you have to operate and close off the rectum completely and the anal canal, that means that the person is going to have a permanent bypass. That's called a colostomy, and not going to be able to use the bathroom in the way that they were going to ever. So it's a life-changing event for that person. So this is a very sensitive topic. You do have to be very empathic about it and deal with the patient very carefully. You have to explain that in trying to cure the disease, this is what is going to be required. So you have to choose life over that change in your function that is going to happen. And this is a part and parcel of any cancer surgery, like Madam explained about the breast as well. Many people require a mastectomy. You don't have a choice. You try to preserve the breast, but due to the disease, which is extensive, you do have to remove the breast many times. So it's a complete change for that person. It's a complete change for the woman. So these surgeries are definitely morbid to the patient, and you have to be very sensitive in dealing with these aspects, and it does take a lot of time with the patient, a lot of counseling. 2-3 times they meet you and they discuss these things, and mentally they have to be prepared, and you have to make them mentally strong.
So when it comes to the future of surgery, surgical oncology, what is it? Robotics, precision, or something else?
When you talk about robotics, it's not something that is changing surgery in the first place. It's a different technique of doing the same surgery. So the surgery has not changed. So as I explained, the organ removal is not going to change. It's going to be the same. If I have to remove the rectum in the patient, it's going to be the same, whether I do it robotically or open. It's the technique which has changed. So robotic surgery offers you better, precision, yes, but more of, reducing the scar, reducing the pain, reducing the hospital stay, reducing the blood loss in surgery. So because of these advantages, it's a better system, you can say. But the surgery inside remains the same. It's not going to change. So robotic is just using a different technique to do the same surgery. In terms of surgery, a lot of change has happened in the terminology of functional surgery. So now the concept of cancer surgery, which used to be that it's radical, remove whatever you can because it's cancer and the person has to be made free of this cancer, has slowly moved on to understand the biology of the disease and select the patients which can undergo lesser surgery, and you can give them better functional as well as cosmetic outcomes. And this is the future, I believe. Rather than robotic and open, that debate, I think the future of cancer surgery should be directed here, where you try to do better surgery and preserve better function for them. Function, cosmetic outcome, whichever, quality of life should be better. That should be the future.
And there are so many advances. For example, he referred to rectal cancer. So there is a type, of course, it's a small percentage of patients of rectal tumors, which when you study, like Dr. Srinivas mentioned, the biology of the tumor or the biopsy, it shows you that there is a genetic defect called MSI in these tumors.
MSI?
All right, MSI.
Okay.
MSI tumors have been studied all over the world, and there is data to show that patients can undergo only immunotherapy for 6 months to a year without undergoing surgery. All right? Most of them get cured, but then what is important is every 3 months coming for a follow-up, they do a biopsy or they do a assessment, and these studies have been published. And a lot of people who have that facility are adopting this all over the world. You want to talk a little more about that trial?
Right. So, these are initial studies where they've taken a selected group of patients who have this particular target again. They have to have this target where immunotherapy can work. And that particular drug is, eliminating the tumor completely from the rectum. All those patients who had this complete response have deferred surgery for now. They're following them very closely. Every 3 monthly, they're doing this investigation. They'll do an MRI, they'll do a PET scan, and they'll see if the tumor is coming back or not. And as of now, all the patients who were treated with this specific drug, the number is small, it's not very high, but all the patients still are disease free. They don't have a recurrence, and it's a very promising treatment in the treatment of this particular group of patients, in which if it really pans out and it works well, then they can really avoid surgery and not have that problem at all what we just discussed. So it's
that's the way we're heading.
Something to look forward to.
And this study, this data is from Memorial Sloan in New York, so it's reliable data. So there are a lot of advances happening in our field. It's a very...
So one advancement which is coming up and you're really excited.
So I think medical oncologists only think about drugs to help the patient. So one such drug that we are excited about, it's already there, we're using it, is an antibody drug conjugate. So ADC is the future of cancer treatment. What is it? It's an antibody, like you give a vaccine to a patient. So you have a target and you have a vaccine towards that target. So similarly, when you have a target like, say, for example, a button on the outside of the cell and the name of this target is HER2, okay, HER2. It can be on any tumor type, it can be expressed. So you have the antibody that blocks it, but attached to the antibody is the chemo drug. It's very smart
Acha.
technology.
Oh, wow.
That's why it's called a ADC, antibody drug conjugate, all in one package. Now you imagine when it gets attached to that button, it goes inside the cell, the chemo acts inside the cell to kill it, and some of this chemo comes out and kills the cells, tumor cells, which are not expressing the HER2 target.
Okay.
So it has this additive effect.
Okay.
We've had some fabulous responses. The drug is most useful in breast cancer, but we also use it in gynecological cancers, lung cancers, colon cancers,
Wow.
gastric cancers, and they are now applied for a pan-tumor approval that any tumor that you test expressing a little bit of this target, doesn't have to express much, this drug will work.
Wow.
And it's in patients who've completed number of treatments, have failed number of treatments where it's working. So obviously now we're studying it earlier on. So I think Dr. Srinivas and I are both very, very excited about this drug. The name is TDXT,
TDX.
and it's a antibody drug
So hoping
conjugate.
for that to come.
So ADCs are the future of cancer care. They're going to come up for every malignancy. Just a smart way of delivering chemo right to the cell.
Right.
Into
very,
the
very,
cell.
very
Correct.
correctly
Correct.
aiming at it. Same question to you, sir. What is that coming up in radiation that excites you?
Oh, I have a lot
I
of
think
things.
sir has lots to speak. We are all ears.
But I'll just tell you, I think precision oncology is one where we're giving immuno and targeted therapies, and SBIT has come a big way. Suppose there's 3-4 meds here and there, you're giving targeted, you target all those with definitive spot like brain, your spine, your hips. There are multiple areas of meds where you target and you then prolong your life and then do. But if you specifically ask me what is more challenging, what is more interesting, which is coming up, is probably imaging in radiation. See, if you look at, we've been treating radiation with the X-ray images, then we moved on to something CT. Now what has come up is MRI based Linacs. So they are so precise, they pick up tumors, they even, during treatment there's adaptability, there's tumors which shrink, change the shape and size of the tumor, then you can target that very precisely. And more importantly, now using PET integrated Linacs have come. Probably there's one company which has come with a PET Linacs where it is not on CT but it is on PET CT. So you don't have to do any imaging, you get a patient, you do a whole body PET, and in the same integrated setting you radiate. So that's one. And another recent thing what I read about is probably misnodazole PET. So there's basically radiation acts well when the cells are not hypoxic, they're well oxygenated cells. So this misnodazole PET picks up hypoxic areas. So targets are very defined. So you don't treat the entire tumor because you shorten your treatment time, you shorten your target, and you target only that hypoxic area.
Acha.
You understand? So that is where resistance is for the radiation. Hypoxia means resistance for any cancer treatment. So that area is picked up and then you radiate. You're doing that. And another thing which has probably come up in US and Europe now, few areas, is flash radiotherapy.
Acha.
So
Flash radiotherapy.
Flash radiotherapy, very unique. So if you see our Linac or protons or even the tomotherapy which we have, we are doing it with probably like we treat around 2 gray, 4 gray, which is delivered over a minute or this thing. Now with flash radiotherapy, you're delivering 40 to 60 gray in a second.
In a second.
So that's a flash.
Like a flash mob.
Yes, and it
Good God.
so effective. The trials are coming. Probably flash radiotherapy is going to be the future in next 5 years or so. So you're so precise. It's like you're shooting a higher dose with precision, with accuracy.
So kudos to this team and kudos to the great work that all of you are doing. And honestly, the word cancer is such spine chilling word, but then it's all because of great path breaking work which you are doing. We still have hopes and we look forward to the treatments. So thank you so much to each one of you for joining me in this panel today. It was a very informative and beautiful session. And I just don't feel like ending this, but I'll have to now. So looking forward to having again all of you on this. Till then, thank you so much. Thanks.